session today. We're just going to jump right in. Tammy, I know we have your case up first, so I'll just pull it up for you. Let me know if you'd like me to scroll up or down. Thank you.
Okay. All right. Thank you. Okay. So this is a 53-year-old male. He originally is from Roane County. He was using IV meth and snorting opiates. He had been in treatment several times, but came to me after going into a new treatment. And he's been here close to I've been seeing him almost a year now. We have his weight is 187, BMI 26.1, his height 5'11", blood pressure normal at 126/86, heart rate 92, O2 set 97%. He did have an abdominal ultrasound, and the ultrasound was completely normal, with his liver being homogeneous, echo texture, and normal in size at 13.1 centimeters. See his comorbidities: nicotine dependence, overweight, a history of hepatitis B, and IV drug use. The only medication he is on is vitamin D, 50,000 units weekly. And he is immune to Hep A. And Hep B, he had one injection when he was in jail, January 2019. We gave the second one December 20th, and I did a surface antibody quantitative at that time, and it was 23.1. And he has an appointment back next week to get his second Hep B. And I can repeat the level next week, the surface antibody quantitative. See. So we're going down to his labs. You see his white count was normal. Hemoglobin was 15.4. Platelets, 279. His BUN and creatinine was within normal limits. Glucose was 87. Protime 11.2, INR 1.1. There you see his liver enzymes, the ALT 42 and AST 31. Alk Phos was 112. And his total and direct bilirubin, total protein 6.9. And his APRI was 0.278. Child Turco-Pugh 5, and his MELD score was 8. And his iron levels were normal. His vitamin D was 36.3 at the time, but I was trying to raise that up to 45 or 50. HIV was negative. He is genotype 3, and his viral load was 1,390,000. His serum fibrosis biomarker was 0.19, and that is F0. His sodium 135. His RA antibody was negative, and Hep B antigen was negative, but the core antibody was positive. And so my question was, how high does the Hep B quantitative antibody need to be? And I know on another patient that I presented at some time, I think the ideal for him was 100, but he had significant health problems, a little different from this guy. And so the treatment options that I thought would be Mavorette 3 tablets daily for 8 weeks, or Epclusa 1 daily for 12 weeks. And I'm not totally sure about this, but I was thinking he would need resistance testing since he is genotype 3. So I welcome your comments and expertise.
Thank you so much, as always, Tammy. That was a great case presentation. I'm going to leave the case up for anyone who needs to refer back to any labs or anything, but certainly we'll open it up to any questions from anyone in the group. If you all have any clarifying questions, anything, just feel free to unmute and ask away.
Oh, go ahead, Tammy. I just wanted to offer it up to our fellows if they want to speak up first before Dr. Gilfreeze and I interject. But I didn't mean to interrupt you, Tammy. If you have any other questions, yeah, go for it.
Oh, I said I've been seeing him almost a year, but actually I didn't see him until June of 2020. And I didn't hear what you said, Kaylee.
Oh, I was just offering up for our fellows to speak up with any recommendations or questions they had first before Dr. Gilfreeze and I interject. I just wanted to give them the opportunity.
Okay, great, thanks.
And to any of the ID fellows as well, if you'd like to chat in, I'm more than happy to read it out as well. Right, and any hub members with any recommendations, comments, or thoughts?
I'll speak up if nobody else wants to. I'll go for it because I know we're in the interest of time. But Tammy, I want to thank you so much for presenting your cases, and I can see how your thought process is getting more advanced the more cases you present. So great job. Kind of the first thing that I'll address is your question about his Hep B titer. And so, you know, I can see where your thought process is going as to wanting to vaccinate him. You mentioned his Hep B core antibody was reactive, so we know that he has had exposure to hepatitis C, and his surface antibody at baseline was 23.1. And I believe your question was, you're giving him vaccination now, and how high does his antibody need to be? And I'm assuming this is based on, are we worried about reactivation when we start his direct-acting antivirals? So, you know, when someone has been exposed to hepatitis C, most of the time as an adult, they're going to actually control that infection to where it becomes inactive, and we don't tend to worry about reactivation or chronic hepatitis C. With a surface antibody that's at least 10, that does confer protective immunity. And so we wouldn't tend to worry about his hepatitis C reactivating at baseline with these direct-acting agents. Now, I think where you were getting the concept of trying to get it above 100, we have spoken in the past, more so from a theoretical standpoint than something that's really been described as well in practice. But if someone has an isolated hepatitis C core antibody that's reactive, so they didn't infer that protective immunity by having this infection, then kind of the concept is we could potentially vaccinate them or revaccinate them to see if we can induce that immune response. And in that instance, if you vaccinate and are isolated core patients and can induce an immune response greater than 100, then we would kind of be more confident and not feeling like they would reactivate. So again, that's more of a theoretical concept. And since we have access to Hep B vaccines, we kind of have said to try that. But since his baseline surface antibody already shows that he conferred natural immunity, you wouldn't necessarily have to be worried about him reactivating. So does that answer that question?
Yes.
Cool.
Thank
Good.
you.
Okay. Yeah. Great. And then you had your options as far as treatment for him were spot on. You know, our two pan-genotypic agents are Mavorite, which is 3 times daily with food. He could certainly do 8 weeks or 2-month treatment course. The other option is the Epclusa once a day for 12 weeks. Now, in the setting of a genotype 3 patient, we would need to get resistance testing if he had liver cirrhosis at baseline. He doesn't have any advanced fibrosis or anything to suggest that, so you wouldn't necessarily need to do resistance testing in him. But I see where that thought comes from, because our genotype 3 patients, we do need to think a little bit deeper on and make sure that they're not cirrhotic, or we do need to consider that NS5A resistant.
Okay.
Either option would be great.
Thank you so much, Kaylee. Anyone else with any thoughts, comments, or recommendations for Tammy?
This is John. I agree with Kaylee 100%. I certainly would not do resistance testing in a non-cirrhotic genotype 3. And I think it was my fault that raised the issue about the Hep B antibody titers being greater than 100. And I should have better explained the context. And I thank you, Kaylee, for clarifying. Period. With this lady, or guy, I'm sorry, I think his Hep B is done. He's got protective immunity, and you don't have to worry about it anymore, unless in the future he would undergo an organ transplant or severe immunosuppressive chemotherapy. And it's those situations where the antibody titer really matters to get it high, as opposed to direct acting antiviral usage, period. So it would be like using, this is for the ID fellows, Rituxan and some of the organ transplant medications, where the quantitation of the Hep B antibody titer really matters. But this guy, I agree with Kaylee, I would not do anything more with his Hep B. He has a protective immune response. I wouldn't check a titer again, nor would I give him any more vaccines from that perspective.
Thank you, Dr. Gilfus.
And Tammy, were there any other questions you wanted to have addressed with the group?
No, I think that's it.
So thank you so much as always, Tammy. Great case as always. And
Thank you.
Kaylee and Dr. Gilfus for the recommendations. All right, Shayna, I have your case here as well. Anytime you're ready, I'll just turn things over to you, and just let me know if you'd like me to scroll up or down.
Okay, great. Thank you. Okay, this is my first time presenting, so I apologize if I stumble. So this is a 40-year-old female. She is actually a patient of one of my coworkers that sees her as a PCP, but she was referred to me for treatment for Hep C. She blood pressure is pretty stable, 140/92. You see her vitals. She had her ultrasound done. Had a little bit of hepatomegaly. She was 20.8 centimeters, but was homogeneous. She was diagnosed with Hep C around 5 years ago at, I believe it was Camden Clark, and was seeing a PCP in South Charleston, but she never actually did have treatment for the Hep C after she was diagnosed. So this would be her first treatment. She has a history of drug use that started when she was around 14. For about 25 years, she used mostly just oral and was snorting opiates for about 25 years. And then she started using IV drugs about 7 years ago, and did that for about 7 years. She's been clean for around a year, probably a little bit longer than that now, and is going to Road to Recovery for her Suboxone treatment. Has been done really well with it. Her urine drug screens have all been negative from them. She does use alcohol on occasion. History of diabetes, bipolar disorder, polyneuropathy, and some asthmatic bronchitis. With her medication list, she's on, and some hypothyroid, I forgot to put that on there. She's on some levothyroxine, some vitamin D, the lithium, she's on 450, 2 tabs a day. Of course, her metformin and her omeprazole, and she's on ropinirole daily, and then her Suboxone. She is immune to Hep A. She was antibody positive, and she had 2 Hep A vaccines. One was in 2017, the last one was in 2018. And she was reactive to Hep B whenever we checked it. And she has had that vaccine series. I think she had a repeat because her last one was in 2018. BMI is 24.3. She 68 inches, and her weight was 72.57 kilos. Lab results, her white blood cells were normal. Hemoglobin and hematocrit were pretty good. Platelets were 173. Creatinine was 0.62. Glucose was elevated. Her blood sugars run pretty high. She's not very well controlled because I think there's a compliance issue there based on what her PCP was telling me. So proton was 10.9, INR was 1. Albumin was 3.4, her ALT, AST, and alk-phos are there. Alk-phos was 184. Total bilirubin and direct bilirubin, and her protein was 6.9. APRI was 0.55. Her child Turco-Pew was 6, and her MELD score was 6. She is HIV negative. I was trying to see if there's anything else. Her genotype was 1A, and her viral load was 740,000. And that measured her biomarker around F1 and F2 at 0.46. So the only real question that I had as far as best option for treatment, but also I was concerned about if there would be any potential interactions with her, things like her lithium and her Hep C treatment. I couldn't find anything, but I wanted to check just to make sure.
Awesome. Well, first and foremost, Shayna, for your first time presenting, that was awesome. So thank you so much. You already sound like a pro. So thank you. Anyone with any clarifying questions for Shayna in her case that she just presented?
I don't know if it's so much a question. I guess one question for Shayna and one for the larger group. She was tachycardic on the vitals. Is she always that way?
Yes. Yeah, that's pretty routine for her.
Okay. And I guess the question for the hub folks is, whether that sky-high blood sugar is going to affect the treatment. Whether it's going to make it, just have an impact on it. That was a question in my mind.
Thank you, Dr. Rexroad. Yeah, we'll open it up to any, responses, recommendations to both Shayna's question and Dr. Rexroad's question. And if anyone needs to refer back to the case, I'm more than happy to pull it back up. So
Mitra, should I go?
That sounds good. I noticed you on mute.
All right. Yeah. Hey, great job on your presentation. Yeah, good stuff. To talk about the sugar, I don't know the answer to it. It's a great question. You know, certainly there might be an association between diabetes. I can't remember, is she type 1 or 2?
She's type 2.
2. It's interesting. Her BMI is really tiny. Yeah, she's a type 2.
Yeah.
Anyway, yeah, regardless, you know, there's a association between worsened sugar control and having untreated Hep C, but I don't know of the corollary of poor response to treatment. If we were still back in the days of trying to augment someone's own immunologic response to treat the Hep C, such as interferon days, I'd probably sweat it a little more than in the direct-acting antiviral days, where we're really trusting these medications to do the heavy lifting, as opposed to trying to stimulate the immune system. And you all know that you know, high sugar and diabetes is certainly a form of immunosuppression. So maybe if this were in the early 2000s, I'd worry more about the sugar being an issue. But at least in this scenario, I'm optimistic we'll have luck treating. She's a great candidate to treat. I'd grab this opportunity when you can. Has hepatomegaly. She's got at least some evidence of fibrosis. She's probably 20 plus years into her infection, judging on the time frame of when she started using drugs. And so it's an ideal time period to treat her. And, you know, sky's the limit from the therapeutic you choose. She's basically being a genotype 1. You could use any of the 4 major medications. Of course, with Zepatier, you'd have to do resistance testing. There might be an issue obtaining one or the other. I can't remember what her insurance was. But anyway, Harvoni, Epclusa, Mavorite, and Zepatier all theoretically could work fine. And I think I would just try to treat her as quickly as possible. To my eyeball test, the PPI is the only drug interaction that I'm, you know, have memorized to be aware of. But fortunately, we've got brilliant people on the call. We have Rachel and a couple other people from the specialty pharmacy. I had to ask for your assistance on the Requip and the lithium, and maybe a reminder on how to dose the PPI if you do choose Epclusa or Harvoni. And then lastly, she is somebody who you probably do not need to do long-term HCC screening on. You've caught her early enough that she probably does not have advanced fibrosis. So hopefully if you treat her now, it'll be just a win-win all around. You'll treat her, you'll cure her, you'll hopefully improve her sugar control and all that stuff.
Great. Thank you.
Hi, this is Rachel. So just to piggyback off of that there, as far as drug interactions go and the insurance, so it looks like she has West Virginia Medicaid. So the options for her that are on their preferred drug list would be Mavorite or Epclusa. From a drug interaction standpoint, the main issue is going to be the PPI. So that dose of omeprazole, if it is the 20 milligrams daily, would be okay with the Epclusa. But there are the special administration points to remember. She needs to take the Epclusa with food and then take the omeprazole 4 hours later. So sometimes that can be tricky with trying to coordinate that. So no, we don't worry about that interaction with the Mavorite. And as far as the lithium and the ropinirole, those are both fine. No clinically significant interactions that we worry there about increasing toxicities or side effects or anything like that. So really the main issue with those 2 options, the Mavorite and Epclusa, is going to be the omeprazole with the Epclusa.
Okay. Thank you very much.
Thank you, Rachel. Thank you, Dr. Gilfus. We got a chat in from Leslie asking if the patient isn't compliant with the diabetes medications, do you think she would be compliant with the HCV medications? And I'll open that up to the group as a whole, the hub members, participants, anyone who would like to comment on that.
I'm hoping that she will be, because she's very motivated to get her Hep C treated. The couple times that I've actually seen her, she's been very, very eager to get it started. So I'm hoping that she'll be more compliant with the Hep C treatment than with her, than what she is with her diabetes.
Maybe you could even use it as a motivator for her that once or while she's getting her Hep C treated, that, her diabetes, if she doesn't get it under control, will eventually affect her liver, or could affect her liver as well. And since she's taking care of it with the Hep C, why not, be holistic in her health for herself? Maybe that would help her.
Thank you, Jen. Kaylee, was there something?
Yeah, I just wanted to thank Shana for her first presentation. I think you did a great job, and you went right through it. I don't think you were very thorough with everything, and you took a great history for her. Her social history was awesome. I think if your assessment is that she's really motivated for Hep C treatment, sometimes we do receive patients that kind of aren't engaged in some of the other chronic issues that could be much more detrimental to their health in shorter order, but they are really motivated for their Hep C treatment. And so just really stressing that if she does pursue this at this time, it's probably going to be a one-time shot for her getting coverage. And so she's got to be very mindful about taking the full course and not having any interruptions, and being forthright with you if she has any trouble taking it, so you guys can troubleshoot. The only other thing I would just want to bring up is, she's 40, and I think you mentioned that she was currently single, but just keep in mind, if she's still of childbearing age, making sure to get a pregnancy assessment before and during treatment.
And that's something I forgot to put on there. She does have a Nexplanon. She had that inserted, yes, by her GYN.
Okay, perfect, wonderful. Okay, then you don't need to worry about it then. All right, that's the only other input I had, but thank you so much. Keep presenting cases. I think you did a wonderful job.
Thank you.
Absolutely. I 100% second what Kaylee said. That was a great job, Shana. And we do always get excited with new case presentations, and you did such a wonderful job. We hope you can submit more, and that goes out to everyone too. If there are any cases you'd like to present and bring to the group, we'll be more than happy to schedule you to present. So thank you to both Shana and Tammy for the 2 cases today. And before we move over to the didactic, Shana, were there any other questions you wanted to address about your case before we move to the next part?
No, you guys covered it. I appreciate the help.
So sounds good. Thank you so much. And Christopher, I'll pull up your didactic for you and just turn things over to you. Just let me know when you'd like me to advance your slides.
All right. And so I'm Chris Hale. I'm with Rational Drug Therapy Program. If you're not familiar with us, we do the prior authorizations for West Virginia Medicaid, PEIA, and CHIP. As far as it goes with Hep C meds and HIV meds, it's only West Virginia Medicaid that we handle there. The PEIA and CHIP plans, the specialty meds, go to CVS Caremark. So what I'm going to kind of present on will be mostly on West Virginia Medicaid. I'm sure a lot of providers in the spokes see a good number of Medicaid patients, so hopefully this will still be useful to them. So you can go on to the next slide. So just quickly, what I'm going to try to go over is, first I'm going to try to show you where West Virginia Medicaid's website is. I'll give you the links for that and kind of show you where to find a lot of these resources that you can use in acquiring a PA that you'll need to know. After we go through that, which will probably be the bulk of the presentation, I'll show you quickly a link for like other Medicaid programs, a good reference or resource for that. And then we also talk about HIV medications in this echo, so we'll go over those real quickly for Medicaid as well. Go to the next slide. So for this page, this is really what I wanted to show here was just, this is a link for the main page for the West Virginia Medicaid pharmacy site. This is what it looks like. You have there across the top, there's a header and this teal ribbon. And in that ribbon, you have 2 links, one for PA criteria and one for preferred drug list and coverage details. And those are going to be the main 2 links that you'll use to find information that you might be interested in here. So if you go to the next slide, you can see what we would see if we click on that preferred drug list link, which is a good place to start if you're interested in coverage on any medication with West Virginia Medicaid. The page will look like this. It'll still have that header and the blue-green ribbon across the top, but this will be what it looks like if you look a little bit down further. Scrolling down to the bottom of that page, you'll see at the bottom there's a list of archived preferred drug lists organized in columns by year. In most cases, you're going to be interested in the most recent one, which would be in the left-hand column. So if you click on that, that will get you to the preferred drug list for the current calendar year. In this case, it's January 1st, 2021. And all these have the links if you want to bookmark them, so you can have easier access to them as well. But if you click that page, go to the next slide. It would open up a PDF document, and in that document, you have drugs organized by their class. Each class will have, usually at the top of the class, there'll be a heading which has some class criteria if it applies, and then you'll see 3 columns below that heading with preferred medications in the left column, non-preferred medications in the middle column, and then over on the right column, you'll see maybe more specific criteria that might apply to only one medication or to one indication. That's the general setup. If you're looking at the most recent January 2021 preferred drug list, you'll see the hepatitis C treatments are on pages 34 to 35 of that document, and the HIV medications are on page 23 to 25. So the next page should show you what one of these classes look like. Here I have the Hep C treatments, which is what we're interested in. So again, it has the header at the top, Hep C treatments. It has the class PA criteria, the preferred medications on the left, which are saying Epclusa, Mavorite, Ribavirin. Zepatier is listed there, but we'll go into a little bit more detail when we look at the preferred regimens. Non-preferred medications there in the middle column is pretty much everything else. And then down the right side, we said that's where we'd find maybe more specific information about this class or specific drugs. And both in the header and in the right column there, it's saying pretty much there's too much information to fit on this page here that you need to know for PA. So it's linking you to the PA criteria page. So if you can click that, that'll get you to that page. Remember, at the main page, there was also that link in that blue ribbon to get you there for PA criteria. So you can get there either way. But if we go to the next slide, we can go over what that looks like next. So this is what this one will look like. This page still, it's going to have that header and the blue ribbon across the top. Your drugs here, or the criteria documents, are organized alphabetically. Sometimes it can be a little tricky to find what you're looking for because sometimes the criteria document would be listed by the name of the drug, by brand name, sometimes by generic name, sometimes by the name of the class. In this case, we're looking for Hep C PA criteria, so you can see it in the list there, alphabetically in the H's. If you click that, it'll bring up the criteria document, which would be what we would focus on, and is probably what we're mainly concerned with. So you can go to the next slide. So to bring up a PDF document, and I'll try to go down through it in sections since we don't really have the PDF here. I tried to cut it up onto the slides. The top of that document is going to have the letterhead, and then it has a few links there right at the top that'll be important for the prior authorization process. You have the patient prescriber agreement form, which is will link you to another PDF document that it needs to be completed and sent in with your request. And you also have the prior auth request form, which is the PA form that would need to be sent. So those two need to be sent in with any initial request. There's some other links there with the continuation request, which you really only need that if your patient's on a regimen greater than 12 weeks, and then the Hep C treatment algorithm attachment, which is also included in this document, but that's going to be the one that kind of describes what regimens will be choices for your specific patient and their genotype and their cirrhosis status and things of that nature. We'll go in more detail on that. And if you go on to the next slide, the way I have these set up, if you were to scroll down the PDF document there for the PA criteria, it would go over the criteria. So I've put in the blue boxes on these slides the word for word criteria, and then I've added a little bit below that as far as like comments. So the first criteria that they say is basically that they require that the medication be prescribed by or in conjunction with a specialist, like a gastroenterologist, a hepatologist, infectious disease physician. It does say in the criteria that consults are permitted, and they would accept ones from this program, from HAMP. The way you'd show that you've met this part of the criteria is on the PA form at the top. If you are a specialist, there's a section for who the prescriber is, there's a box for that prescriber specialty. If you are a specialist, you'd fill in an infectious disease prescriber, or whatever you are. If you're not a specialist, or you've consulted, for example, with ECHO, on the second page of the PA form, right before the signature, there's a box where it would ask you to put in who you consulted with, their contact information, what their specialty is. So if you're through the ECHO program, you want to make sure that you include who you consulted with in that section of the form. Go on to the next slide. Two of them on this slide. The first one is basically just that the PA form and the patient prescriber agreement have to be completed, or else the request will be denied. Generally, if there's anything missing on the prior auth request when it gets to us, we would usually just send it back asking for it to be attached. We usually won't deny it outright if it's missing something. We just point out what is missing and ask it to be submitted. The next thing here is that the patient must meet the minimum FDA approved age requirement as specified in the package label. All the ones that are on the market right now are indicated for 18 and up. So this is really only kind of discussing the pediatric patients. Like we saw there on the preferred drug list, Epclusa and Mavorite are our preferred regimens, and those are the pangenotypic ones that we'll see. Those can be used, Epclusa down to age 6, Mavorite down to age 12. Harvoni, being a non-preferred medication, can become an option for patients that are in that age group where Epclusa and Mavorite are both not indicated. We'll go into that a little bit more in detail. There's a later bullet point in the criteria that explains that a little bit better. But this is just kind of a reference of what the age groups are right now for the FDA labeling. So going into the next slide. The next criteria point is in regards to viral loads, and the requirement is that they want to see the Hep C viral load from the last 6 months, so something current to be submitted, and then also another viral load from 6 months prior to that. And the goal of this portion of the criteria is to establish that the patient's hepatitis C is a chronic infection. You'll see that some patients, there's a significant chance that if they had just acquired the infection, usually you see quoted around 15 to 30%, that if they just acquired the virus, they could clear that on their own. So we want to make sure that this is a patient who was afforded the chance to clear it on their own and did not, and that it is a chronic infection. With that being said, sometimes you might not have a viral load historically, but you may have evidence that the patient does have chronic infection and it is longstanding. A lot of times we'll see maybe you don't have a viral load, but maybe you have an antibody from at least 6 months prior that would kind of establish that that virus has been there longer than 6 months. Or you may have documentation in a chart note from a previous provider or at a previous institution that they had that listed in the problem list or something like that. So in those cases, we can accept that node or that antibody in place of the historical viral load to establish the chronic nature of the infection, but we do still require one viral load from the last 6 months for that more recent one. Go on to the next slide. So the next part of the criteria says the prescriber must attest to the best of their knowledge that the patient has abstained from the use of illicit drugs, excluding marijuana, and has not abused alcohol for a minimum of 3 months. This portion of criteria is addressed exclusively in the patient-provider agreement, and we only require that that attestation be completed. We don't require drug screening labs be sent in, but if they are submitted and they show that they are testing positive for something, then that might be something that we ask to be clarified, an explanation why they're testing positive, and you're testing that they have been abstinent. I think this is one of the sections of the criteria that maybe garners the most scrutiny, because more and more we're recognizing substance use disorder as a chronic condition, one that the patient won't be cured of, and there's probably also still some public health benefits of treating as many patients as possible, even if they are active users. But I think one thing that shouldn't be lost is when we talk about the morbidity and the mortality horizon of hepatitis C, we're talking about decades. And when we compare that to substance use disorder, oftentimes, sadly, you'll see that that could be the thing that affects their quality of life, mortality sooner. So I think this part of the criteria is trying to encourage is that those patients get that linkage of care to substance use disorder, that it's not skipped over or neglected, and these patients are in a point in their life where they'll complete their treatment, they won't be lost to follow-up, and they'll hopefully be able to realize the benefit of the cure of their condition with these treatments. The next part of the criteria mentions that they require that the patient be immunized or have immunity against hepatitis A and hepatitis B. Usually what we ask for there is either the immunization record showing that they've at least started the vaccines and are up to date with each of the doses, or we see the serology labs be attached showing that they have antibodies to each of those viruses. One thing to point out is that Medicaid at the pharmacy for patients 19 years of age and up, they'll cover all of these vaccines at a pharmacy. So if there's a situation where maybe the patient hasn't started these and you didn't give them the dose and they aren't immune, they wouldn't necessarily have to wait to come in to the office to have that dose given. And you can always call them up and say, hey, get down to CVS, Walgreens, their independent pharmacy, and ask to have these done. And when you have them done, they can just call you and you can resubmit their request. If they get them at the pharmacy, we can see the claims billed to the plan too. So we'd be able to verify that they had gotten them and were up to date at that point. So that can be a little bit easier for the patient and for you guys as well. The next slide, just as a reference, has the vaccine schedules for hepatitis A and hepatitis B and which ones are out there. These would be, usually we'd refer to this if they've started their vaccine, we'd see what their dose is and make sure that they aren't due for one. Because if they are due for a dose, we want to make sure that they get that in before we approve the treatment. So that's just kind of there for reference. The next slide. The next slide refers to after treatment. Medicaid requires that after the treatment is completed at week 12, that SVR12 be collected and submitted to Medicaid to confirm success. And if you look at the bottom of the slide, they have their statement about coverage limits, and Medicaid has stated they'll cover one successful course of therapy in a lifetime. So it's important to get that one after 12 weeks to confirm that it was successful, because they also say if you don't get that they'll just assume it was successful. So always checking never hurts and is part of quality of care. If they were to be someone that you got the viral load at week 12 and they had not cured it, they would still be eligible to move on to a salvage regimen, maybe like Vosevi, or if they weren't treated with one of the other regimens, those may be options. They said reinfection will not be covered except at the discretion of the medical director in case-by-case basis. We actually will reach out to you guys if we've approved the regimen to let you know around when that SVR12 will be due. Sometimes the dates can get a little bit off. We go with the way we calculate the data is the date we approve it. The approval is in there for the length of therapy that you requested. So at the end of the approval, we add 12 weeks onto that, and that's the first time that we're going to reach out. So usually we'll do 12 weeks, and if we don't hear back, we'll follow up 2 weeks later and another 2 weeks later. So you go to the next slide here, you can see kind of what those letters look like. They're just kind of saying, here's the drug that they got. They should be approaching 12 weeks after the end of their treatment, and reminding that that's something that Medicaid's asking to be submitted. You can have we usually just ask that you fill in there and attach the lab. And then the next slide. The next slide is talking about protease inhibitors and saying that if they have decompensated liver disease, they won't be approved, which these medications are contraindicated in patients with decompensated cirrhosis. So they probably wouldn't be ones that you'd want to use. Remember, these are the ones that end in Previr. So you have your Grazoprevir, and that's in Zepatier, your Voxilaprevir that's in Vosevi, and your Glesaprevir that's in Mavorite. So those are going to be ones, like I said, they're contraindicated in decompensated cirrhosis. They're probably not ones you're going to want to use. The treatment algorithm and preferred regimens list that's in this document aren't going to steer you toward one of these medications if they have decompensated cirrhosis. So this one's pretty straightforward. The next slide, we should see, it goes on to talk about pediatric formulations. And it's kind of what we were talking about earlier. If you're looking at the treatment algorithm and preferred regimens list, which we'll talk about here in a couple slides, which kind of guides you to which treatments are preferred for your patient's clinical scenario. Those are going to be mostly tailored toward adult patients. And Medicaid kind of realizes that at the time the criteria was drafted, that the pediatric formulations were still kind of maybe weren't as tested and was maybe more of a developing area. So they still wanted to make sure that this document could be, you know, if a drug got tested in children, that the children would have access to it. So they basically say that for pediatric patients, just refer to the AASLD and IDSA guidelines, which you can find at hcvguidelines.com. Go to the tab for unique and key populations, and then go to HCV in children. And basically, whatever regimens they recommend there would be ones that we could approve for the patient. Obviously, if Epclusa and Mavorite are options, Medicaid would prefer those because those are the preferred ones. But if the patient's in one of those age groups and where Havoni is the only option, we can definitely approve it for them. We aren't going to make them wait until they turn 6 or 12 so that Epclusa and Mavorite can be used. So go to the next slide. So that's all of the criteria. The next slide here has the treatment algorithms and preferred regimens. This is a pretty lengthy document. I kind of tried to cut it down just so you can kind of see sort of what it looks, parts of it look like, and how to use it. Each genotype will have a heading, and then there'll be clinical scenarios for patients under that genotype heading. So you would just find your patient scenario in that list, and it will point you to which regimens are options. So I think we have here genotype 1A, and I think Shayna, your patient was the one that you presented today who was a genotype 1A, treatment naive and no cirrhosis. So if you were looking up what options would be suitable for her or would be covered on Medicaid, you can see that first checkbox there points you to regimen 1 or 5. If you scroll down in that document, you'll see the key, which is at the bottom of this page. You have regimen 1, Mavorite, 100/40 milligrams, 3 tablets daily for 8 weeks, or your regimen 5 is Epclusa daily for 12 weeks. Remember when we were discussing these, John had said that Zepetir and Harvoni would probably be options too, but in this case, this is going to be a little bit further tailored down to the preferred ones that Medicaid would cover, which are for that patient Epclusa and Mavorite would be your options that would be covered. So next slide. This is just the patient-provider agreement. What that looks like. Remember, at the top of the patient, of the hepatitis C prior auth criteria document, you have the link for that. This is just what it looks like. It's one that you'll have to complete and send in with the PA request. And then next slide. So this is probably going to be toward the end of the, just to wrap up the hepatitis C prior auth process and criteria. Just a quick checklist of what you'll want to make sure that you have together when you submit this in to us. These do have to be sent in by fax just because of how much information we ask for. But you want to make sure that you have the completed prior auth form, the completed patient provider agreement that we just saw, and then we do need a few things attached. We ask for the 2 viral load labs that are at least 6 months apart. And keep in mind that the historical viral load, we can accept like an antibody or a chart note, establishing that it's a chronic infection in place of that. So either have the viral loads or substitution for the historical one and make sure those are there. We do ask for the genotype lab report to be attached, the fibrosis score lab report to be included. And for that, we'd accept either FibroSure or a comparable biomarker test, elastography report or biopsy. And then the last thing is the verification of the hepatitis A and hepatitis B vaccinations or immunity to those. So either the record of what doses were given or the labs showing that they have antibodies to each of those would be accepted. Since you have all those together, just fax it over to us, and our turnaround time on these is usually within 24 hours. So you should hear back relatively soon, whether it's approved or if we need more information. The next slide. This slide here is just if you're dealing with patients who are outside of West Virginia but still have Medicaid, this website here, the stateofhepc.org, is a good place to kind of go for resources on that. They give each state Medicaid program a report card on access to hepatitis C therapies, and they give recommendations how they can improve the access to the patients in their state. Each state gets their grade, and then there's a full report that they've prepared, and in that report they'll tell you whether that state has limitations on whether they'd approve a medication because of liver damage restrictions, or if the patient has to have sobriety for starting long. There's prescriber restrictions, like whether they have to see a specialist or not. So it's a good place to get some general information. I would caution that this may not always be completely up to date. I've seen a couple of cases where criteria had changed for the state and they were still showing the old info, but it is still a good place to go to kind of get started. They can link you to important pages where you can get more information. So just wanted to provide that resource. The next page here will be moving on to the HIV therapies. The HIV therapies are a little bit more straightforward. There's no PA criteria document like there is for Hep C. All the information that you need for HIV is located on the preferred drug list. And the preferred medications actually don't need prior auth. So if you had an HIV patient, any of those patients, any of those medications listed in the preferred ones, you can prescribe and we'll go through without prior auth. And there's a lot more extensive list of HIV medications there. Usually if you wanted to prescribe a combination, there is usually a way to get it by maybe, even if one is non-preferred, you might be able, like a combination product, you might be able to get 2 individual agents that are in that combo without prior auth. So usually we'd encourage that. If a patient just comes over to Medicaid, established on a medication, that medication's non-preferred, we're able to grandfather their approval. Usually if that's the case, it would require a call to us to alert us that you want that approval, and usually we just ask for the pharmacy records from the last couple of months with their previous insurance showing that they've been getting it, and as long as we can get that, we can approve them to continue the regimen. We would not require them to change. The next slide here I have is just the changes on the preferred drug list this year for HIV medications. The good news is this year there's not any significant changes. Everything that was preferred last year is still preferred. Everything that was non-preferred last year is still non-preferred. The one addition that was made was Temixis was put on as a non-preferred medication. That one is a combo product that contains tenofovir DF and lamivudine. There are still ways to get those combinations, though, without prior auth with preferred products, either as the individual agents or as another combo product with the same ingredients called SimDuo. So patients still have access to that. It's just the Temixis formulation that's not preferred. And then the next slide, I think the next couple of slides here, I just tried to squeeze for reference, the preferred drug list onto a couple of slides here. So you have your preferred medications on the left, your non-preferreds on the right. Like we talked about earlier, you can always go to the preferred drug list and see the same information there, but this is just for reference to have it here in the slides. So these are individual medications, and then on the next slide, you'll have the combo products that are preferred and non-preferred. And the last slide I have here is just quickly on the Ryan White program. This is one that Medicaid, the patients use the Medicaid processing information to process claims. So it looks kind of like Medicaid. This is so the patients who might not be able to afford their HIV medications can still have access to the medication. There won't be risk of them not being able to receive treatment because they can't afford it. You also hear this referred to sometimes as the Limited Pharmacy Services Plan or the AIDS Drug Assistance Program, or ADAP. it covers medications only for the treatment of HIV and HIV-related conditions. It's a closed formulary. The last formulary that I was able to see was published was a few years ago in February 2015, and the link of that is right there. If you have an HIV patient, the eligibility requirements, they have to be a resident of West Virginia, they have to be within 400% of the federal poverty level, and they have to be not eligible for other forms of insurance coverage. This is going to be kind of the payer of last resort if a patient is not able to afford their medications. If you have a patient like that, the way they can apply is go down to DHHR, the county office for Medicaid, and ask to be signed up for that. So that's some information on that. And I think that's all I had for this presentation.
Thank you so much. Thank you so much, Christopher, for putting that together and sharing it with the group. And as always, I'll be including his PowerPoint in the recap email so anyone can go back and refer to those links that he had in his PowerPoint. But before we part ways, I know it's like the very end of the session, but if any questions, comments, or thoughts, please feel free to unmute and ask away. I see Jen, you chatted in saying it was very informative. Thank you.
I'm assuming there's still nothing that's the equivalent of Ryan White for people who need Hep C treatment and don't have insurance. Not that I'm aware of, no. And I just wondered if any of our partners who are from Allied Health Solutions know if, I think if that's the case, that sometimes there are some of the pharmaceutical companies have patient assistance programs. Is that accurate? I have a couple people queuing up who need treatment and have no insurance.
Yeah, that's a great option because they'll go ahead and they review them on a case-by-case basis. And I've had several patients who have had pretty decent incomes, but still a lot of these are unaffordable at full cost, and they'll you just fill out the paperwork. It does require tax information, but then submit that to the manufacturer's company, like Gilead has Support Path. So you can submit those directly to them, and if they're approved, the manufacturer will supply them with free drug directly from them or their pharmacy. So you'll have to write an order for that, but it's a really good program. So if your patient is underinsured or has no insurance, that's definitely an option. There's also the option for the authorized generics for both Epclusa and Harvoni now. We use those a lot for our Medicare patients because if they have a plan specifically that requires that they pay a portion of the cost, those authorized generics actually cost about a third of what the branded products do. So we'll use those to take their copay down. And then we can still use foundation assistance for them to bring that copay down to 0 too. So there are still options for underinsured or uninsured patients for sure.
That's good to know, thanks. And then my only other comment, Chris, from your presentation is it's interesting that the patient-provider agreement says that the patient has not abused alcohol. It doesn't say the patient has not used alcohol.
Yeah, I guess I think that's kind of, I think that they were trying to be a little bit lenient with the criteria. I mean, they did kind of go with a little bit excluding marijuana. That may have been why it was worded that way. But yeah, I mean, you can use the patient-provider agreement as a tool to discuss and, with the patient the importance, definitely if they have a history of abuse of alcohol, to and let them know how that can still impact their liver disease and encourage them to be abstinent, but we wouldn't require them to be abstinent in that case, just they aren't abusing it.
Yeah, great, thank you.
You're welcome.
And Kaylee, I noticed you unmuted as well.
Yeah, I did. I want to thank you, Chris, for giving a great presentation, and I really I recommend, he had a couple good slides that maybe you want to print out, like the vaccine schedule, since there's a couple different vaccinations available in terms of like hepatitis C vaccine in particular. There's some dosing intervals that are a little bit variable, so maybe you want to print out that slide for reference. And then also, I recommend in your clinics to go ahead and print off, since we see so many Medicaid patients, print off that patient-provider agreement, make copies of it, have it available in clinic. That way when you're in with the patient, you can go ahead and get that completed together at their visit, rather than having to get that sent out afterwards, because you'll have probably less success getting it mailed back. But thank you, Chris. If you guys remember, you know, even just a couple years ago, we were really having difficulty getting access to hepatitis C treatment for patients that were anything less than stage 3 liver fibrosis. So we've really come a long way. I think even 2 years ago, we were like as far as the state of Medicaid, we were like a D, and now we're a B minus. So we've definitely moved forward. I did want to make a comment. I was going to ask you, Chris, as far as, you know, we do need the SCR12 data, and I think that was kind of a tool just to show that, you know, we are really making an impact. Do you have any updates as far as, you know, how we're doing with submitting that SCR12 reports? Are you guys getting a lot of those back and confirming clearance, or are there a lot of patients that are lost to follow up? Do you have any updates in terms of that data?
Yeah, I did just put together a packet that we sent down to Medicaid about what we've gotten back so
cool.
far.
Okay.
I think the general consensus was that we're a little bit disappointed in how much we're getting back.
Oh man, okay.
But I would say that I didn't look through specifically each provider by name. We just had a list, but I did pull up a few who I saw who were doing well and who we weren't really hearing back from. And I can say that this group in particular seems to be doing a lot better job than the general group of practitioners. So definitely kudos to everyone here. I think some of the reason, I can tell you the number that we saw was around 30% of SCR12s we were getting back, which is why we were hoping we'd see a little bit higher than that. But I mean, the last year's been kind of crazy. We started capturing the information in regimens that started in October 2018. So if you think of 8 to 12 week regimens plus 12 weeks, that puts you right around March 2020, which is when this all started. So I know that there were probably some patients who didn't want to come into the office. So that might be why we're not seeing as much a response, as much follow-up as we were hoping. And I think we kind of point that out to them. That might be why, but definitely I think it's still important to stress to the patients that it is still important to get that in, because if they don't get it taken and it is shown that they didn't clear the virus, then later on, after, you know, a year afterwards, then they might not be eligible to be retreated. I had one other point that I was going to say that escaped me. Of the ones we did get back, there was only one patient who didn't achieve SVR12. So as far as the effectiveness of the drugs for the people who we are checking, they seem to be doing what they're expected to do.
Okay.
Working really well.
That seems in line with the response rates anyway, with the failure rates. The other question I wanted to ask was if we're making any progress with removing that specialist restriction, but then I heard you mention that the specialist consults have to be with an infectious disease physician. So my question changed from when are you going to include the NPs and the APPs as far as consultants, or do you have any idea when that specialist criteria may be listed?
I don't. We aren't really involved in much of setting the criteria. I'm not sure if Dr. Feinberg was on the call, but I know she's involved a lot with Medicaid and in trying to lobby and advocate for policy restrictions to be lifted and loosened a little bit. So she might have a little bit more information on that. I don't know if that's what that meeting was that they talked about on Monday, if that had anything to do with changing some of those things possibly, but it seems like something that they do evaluate pretty regularly. So hopefully that we can see a little bit better access.
Cool. Well, thanks so much, Chris. I really appreciate it.
You're welcome.
Absolutely. Thank you guys so much. I do want to give a big shout out to Tammy, Shayna, and Christopher for creating such a great session today. So the only announcement I have is our next session will be on February 25th, and Carolyn Kidd is presenting on health education awareness. So keep an eye out for that reminder. We'll see you guys next time. Thanks again.